Hi everyone, my name's Simon Prowse. I'm a consultant ENT surgeon from Hereford County Hospital. This presentation is for the benefit of the West Midlands ENT registrars for their training day on Wednesday the 15th of January 2025. I'm very sorry I can't be with you this afternoon as scheduled, as I've got an unwell child of my own to look after. But hopefully this video will be of some educational benefit. If there are any questions following the video or any clarification needed, if you put a comment below, I will do my very best over the coming days to respond. Managing the dizzy child in ENT surgeon's perspective. I have to say, as a otologist working in a busy DGH, I see a lot of dizzy people, very few dizzy children. I think it's not a common presentation. There's certainly a burden of illness out there, but I think a lot of these children probably don't come to the ENT clinic. I've seen a handful over the years, and there's some common themes which I'll try and pick out. And then there are a few red flags and rare conditions to be aware of. I'm aware that you've already had a talk from some eminent surgeons and physicians this morning about ENT syndromes relevant to childhood vertigo and the specialist investigations for this condition. So I'm really focusing on what to do in a district general hospital when you probably don't have access to a specialist audiovestibular medicine, particularly for paediatrics. Okay, so we're going to talk a little bit about the developing balance system very briefly. We'll talk a little bit about how children present with balance disorders. They don't really present in the same way as adults. And then probably most importantly, we'll spend some time talking about the common causes and their management. So, balance physiology. Well, I mean, there's a whole day's topic there to talk about. Really trying to keep this within a few minutes. I got this image, this really great graphic from a paper on paediatric vertigo, and it shows the pretty standard diagram that you get a lot of balance books, which shows the inputs into the balance system. It says graviceptors. I would say more so peripheral sensation, the feet, so an awareness of the surface you're walking on. Proprioception and haptic perceptions, so touch. The vestibular organs, obviously there's one on each side, and the brain's expecting a sort of symmetrical response from them both. The visual system, which is very important in children. Children are relatively visually dependent. And the auditory system as well, so sound in the environment and localizing of that is very important in maintaining balance. So this is all integrated and synergized in the brainstem and the cerebellum. And then its output via various reflexes, vestibular ocular, so the ability to read a moving book, for example, or read a road sign when you're moving. Vestibular cervical, so very important for posture control and neck control. Vestibular sympathetic, so when you stand up, your heart rate increases and you get a relative peripheral vasoconstriction. So that's an autonomic response to change in movement. And then vestibular cortical, so more higher functioning perception of your own movements, where you are in the world, cognitive and emotional responses. And the interesting thing really with this is it presents all of these really is developed in this graphic of a young child. In reality, children are born with a fairly primitive balance system, and it doesn't fully evolve until the teenage years. So this child here, who I'm guessing is maybe 5 or 6, you won't really have a fully developed vestibular system as such. So we'll go through a few milestones. So here's a little baby, probably about 2 months old. I'm sure some of you have got children of your own. And when they're first born, they don't really look at you. And then as the weeks are going on, suddenly they start making eye contact, and that's associated with the development of the vestibular-ocular reflex. So probably if you were to gently move this baby from side to side, his eyes would remain fixed on you as a source of interest, which suggests his vestibular-ocular reflex is developing, and that's around 2 months. Head control, so there's this young lad who's got trisomy 21. He's probably around 4 to 6 months, and you can see he's lifting his head up, and he's probably able to move his head around and look at the environment. So he's got a vestibular cervical reflexes starting there. He's able to maintain his head posture. That's around 4 months, so you're going to start seeing that. There's another little lad here, and he's probably around 7, 8 months, 6 months, and he's starting to sit unaided. And then we've got crawling, which children should really be doing by about 12 months. Some don't crawl, they bum shuffle. So they'll shuffle around on their bottom. Others seem to bypass crawling and go straight to what we would call cruising, so walking unsteadily, holding onto furniture. But certainly most children, really by 18 months, should be making some attempt at walking. If you've ever seen a child this age walk, they've got a very wide base gait, they've got their hands out, and they tend to waddle side to side. But really by 18 months, we're hoping to see some walking. And I guess one of the points of this slide is pointing out these developmental milestones. So if you've got a child who's not meeting them, is there a reason why? And then a very useful test is the standing on one foot. So really by 3 years, they should be able to manage this for a few seconds before they fall over. And then by 5 years, you're looking about 8 seconds. My son's 6, and I tested him at the weekend, and he was very happy to say he could stand on his foot for 20 seconds. So yeah. As we get older, so this lad's probably about 8 years old, all of those central reflexes that we saw on that diagram, on that overview, are starting to integrate, and children should be undertaking much more challenging balance activities, learning to ride. They should be confident riding a bike, swimming, but they're still relatively visually dependent, and their balance isn't quite as good as an adult. But really, by the time they're getting to 12 to 15 years, we've reached maturity, and all the reflexes should be working in synchrony, and most 12 to 15-year-olds will have balance that's far better than a man of my age in the mid-40s. Certainly when I'm playing with my kids, 6 and 11, if we do anything sort of going on a roundabout or anything, I certainly feel the effects on my vestibular system much more than they do now. So I've probably gone past the peak, but by 12 to 15 years, they should be fully developed. Okay, so how to approach a child who's been referred to you with possible balance issues or dizziness, and one of the issues here is children seeing you in the first place, because very few children, particularly younger children under the age of 6, 7, they won't say to their parents, "Oh, I feel dizzy, I've got vertigo." Very young children, maybe preschool, may not even be able to describe how they feel. The history may purely be based on the parents' perception of the autonomic effects of the dizzy episode. So the quote for this slide is, "Mummy, the house is falling down," and that's a very memorable presentation. It sticks in my mind. As a young girl, I think she was 5 or 6, and she was having episodes where she would quite suddenly, unprovoked, start to become very scared. She'd be frightful, crying, she'd look pale, she'd be sweating, and she would cling on to furniture that was nearby, or she'd cling on to her parents, and she would say, "Mummy, the house is falling down." Now, this child was ultimately having vertigo. She had a condition which we'll talk about shortly, but that's the way in which she described it. Other children have said things to me such as, "Oh, the floor's moving, oh, I feel sick," and it can be quite difficult to tease that out, and certainly you need to spend some time doing that and speaking to the parents and the child. Other things that parents might describe are unexplained clumsiness, periods where the child seems to fall over a lot, bumping into things, falling over in the dark. Remember, children are relatively visually dependent, and so if there's a balance issue, it will often become unmasked in the dark. So going to the toilet in the dark and things like that, they might seem to be off balance. They may also find that they're getting these episodes of nausea and vomiting, which are relatively short-lived, but without any signs of systemic upset, sort of fever or sepsis that we might expect normally. But as I said, autonomic symptoms can predominate. Older children certainly might might describe the usual, feeling dizzy, lightheaded, sick, abnormal movement in the environment, all the things that adult patients with vertigo will describe. Other things to look out for are oscillopsia, so struggling to read when the head's moving, particularly when the car's moving, dizziness when they're playing computer games or when they're watching TV, really bad motion sickness, so being sick in the car all the time, and agoraphobia, maybe fearful of going out sometimes, wanting to be in a closed environment. Most childhood dizziness disorders are episodic rather than chronic disequilibrium. Once you've identified those symptoms and you've teased them out, try and ascertain, is this an episodic phenomenon, i.e. are they completely well between, or is there any sort of delayed milestones that we just talked about in terms of their mobility. Good thing, video evidence now. So parents, everyone's got a mobile phone. Parents love taking videos of their children. And my experience with a lot of things is that parents will now video what's happening to the child. So that can be really useful. I'm thinking about things like nystagmus. So if that's recorded on video, that's really useful. A lot of kids, when they're feeling dizzy, will close their eyes. They want to ask the usual questions. Are there any obvious triggers that seem to provoke the dizziness, or anything that makes them feel better? How long do they last? Is it seconds, minutes, or hours? And then any associated symptoms, particularly as autonomic symptoms. There are red flags which you need to be mindful of. So really bad headaches, particularly morning headaches in young children. So older children can develop migraine, classic migraine headaches, but young kids, junior school, preschool, they shouldn't really be getting really bad headaches. If there's a lot of headaches, or if there's a loss of consciousness during the attacks, or their conscious level seems to reduce, that's not typical of a vestibular problem. Incontinence in toilet chain children during the attacks, again, that would be very unusual in a vestibular disease. Ongoing nausea and vomiting every day, again, that would be a little bit worrying. Tongue biting as well. So these are really red flags for a more serious central problem, something like epilepsy. So temporal lobe epilepsy can certainly cause feelings of dizziness, but it usually be resulting in a reduced level of consciousness, some sort of seizure activity. So just be mindful of this. I would probably specifically ask these questions of the parents, and if you've got any concerns, I would have a low threshold for getting a paediatric opinion. Okay, so we're going to talk about this condition, the first condition, which is called BPTI, or benign paroxysmal torticollis of infancy. I'm going to play a video because it probably describes far better than I can what happens. So hopefully this will play. So here we are. This is a child, probably less than 1, and you can see the head tilted over to the right-hand side, so a torticollis. So that's a classic attack of BPTI. So this condition generally manifests with episodic head tilting. Unprovoked, the child will suddenly seem to develop a torticollis. It normally lasts just a couple of minutes, maybe less than 10 minutes, but there are reports of it lasting for days or even weeks at a time. It usually starts to present around the age of 2 months, and the child will often exhibit some associated autonomic signs. So they might cover their eyes because they dislike the bright light. They may be sick. There may be some pallor and sweating. The episode runs its course, and then they're fine. They go back to doing what they were doing before. A lot of these kids also exhibit motor delay, so they might be slow to sit, slow to walk. It's a harmless condition. The attacks seem to get less, and usually by the age of 3 they've stopped, and certainly by the age of 5 they should have stopped. It's felt to be a manifestation of migraine, so a very early form of migraine with abnormal brain activity rather than being a true vestibular phenomenon. It can run in families, and it's worth asking if there's any family history of migraine. There is a very rare association with wide vestibular aqueduct. So if you have a child who presents with this, I've personally never seen one. I think they're probably more likely to present to the paediatricians because it's not obviously an ENT problem, is it? You know, a child with their head twisting to the side. But if you do happen to see one or are asked to give an opinion, be mindful of this potential association with wide vestibular aqueduct. But why? Because wide vestibular aqueduct is associated with progressive sensory neural hearing loss. So they have a normal audiogram at birth, they pass their, well, not audiogram, they pass their newborn hearing screening, their acoustic emissions, and then they have a progressive hearing loss as they get older. Interestingly, with benign paroxysmal torticollis of infancy, the torticollis starts around age 2 months, but the hearing loss, and this is in children with WVA, doesn't start until around 3 or 4 years of age. So there's this delay. So if you've got one of these kids, I would send them for a paediatric hearing assessment, and I would probably, even if that comes back as normal, I would probably suggest to the audiology team that they keep them under maybe 6 monthly to a yearly review until they reach school age. Hopefully by then as well, they'll have grown out of the torticollis and the audiogram stays the same and you can discharge them. If they start to show a sensory neural hearing loss, then you need to initiate investigations for wide vestibular aqueduct, so neuroimaging. Around half of these children will progress. They'll change from this paroxysmal torticollis and they'll change into what we call recurrent paroxysmal vertigo of childhood. So not to be confused with BPPV, benign positional paroxysmal vertigo. It's recurrent paroxysm, so attacks of vertigo in childhood. It's nothing to do with BPPV. This is also felt to be a migraine precursor. Unlike the torticollis, they'll have a sudden onset of vertigo, again without any obvious trigger or warning. So it's not positionally triggered like BPPV, it just happens out of the blue. It lasts for a couple of seconds to a couple of minutes, and then boom, they recover very quickly. There's no kind of hangover or anything. They'll often shut their eyes, but if their eyes are open, you will see a nystagmus. There's a lot of autonomic symptoms, as I've said, and they're absolutely well between the attacks. Usually starts around the age of 3, up to about the age of 8. There is a slight female preponderance. There is a fairly weak association with a mutation in the CAC-NA1A gene. That's particularly where there's a strong family history of migraine. And there's something which has been termed the vestibular march. And these are children who start off with benign torticollis. They grow out of that and they start having recurrent paroxysmal vertigo. And then then they progress into a full adult migraine. So the child that I described earlier on, where she felt the house was falling down, she had recurrent paroxysmal vertigo of childhood. What do? Well, the attacks are distressing for the child, but they're brief. They're seconds to minutes usually, and then they recover well. They tend to be fairly infrequent. In my experience, children I've seen, they're having an attack every couple of weeks. Of course, it can happen more frequently, but mostly it's about reassurance that this is what this is, that it's harmless, that it tends to run its course, and awareness that it can change into migraine. So treatment is largely conservative. You need to look as an adult, as you would with an adult migraine patient. Are there any triggers such as poor sleep, poor diet? Are they more likely to have an attack after they've been up all night? Interestingly, kids with glue ear, it tends to drive the activity of paroxysmal vertigo. So if they've got concurrent glue ear, treating the glue ear, even if they're below the usual threshold for treatment, will often improve the paroxysmal vertigo attack. So that's worth doing. Some people in the States suggest magnesium supplementation, which has got some precedent. We use it in adults. Medication, I've not used it. In America, they have some first generation antihistamines, which they use, which are licensed, but there's no real licensed medication in the UK for children under the age of 12, really, for migraine. So I would try and treat conservatively. If they're really struggling, I would probably seek the advice of the paediatric migraine specialist if you've got one. So we then move on to vestibular migraine, which about 20% of kids who have got benign paroxysmal vertigo in childhood will move on to develop. And This is probably the most common cause of recurrent vertigo in older children. So um, early teenagers or children coming out of primary school. There's a gain of female preponderance. Um, there's a few interesting things. So headaches aren't universal. So not all children have headaches who've got vestibular migraine. Um, when they do get headaches, they tend to be milder and bilateral rather than the classic hemicranial pain, blinding hemicranial pain that adults get. And there's less of an aura, so they're less likely to get visual aura. Um, the attacks, as with adult vestibular migraine, last around 5 minutes up to about 72 hours. There tends to be quite a lot of light and sound sensitivity, so the child will cover their eyes. They want to be in a dark room. They'll pull a blanket over their head. They want to be in a cocoon in a dark space. In female children, teenagers, there can be some association with the menstrual cycle, with the attacks happening in the premenstrual phase. What do you do with these children when you think they've got vestibular migraine? Well, I've got a big workload of people with migraine, and I always say migraine thrives on inconsistency. It loves the modern lifestyle. So going to bed late, waking up early or waking up late, too much or too little sleep, poor hydration, lots of sugary snacks, irregular meals, stress, lack of exercise, all things that most teenagers experience, it thrives on. So what I will tend to do with particularly my younger patients is I'll get them to have a migraine diary, and there's some really great apps that you can use now where they record when they have a migraine attack, what the symptoms are like, and they can keep a track of things like their sleep and what they're eating, trying to find if there are any triggers there. Really, you want to encourage as regular a lifestyle as you can. So regular to bed, regular to wake up, because too much sleep can be a migraine trigger as well. Regular meals, good quality sort of low GI food, not lots of sugary snacks, good hydration, and try and manage stress. So that's really hard with most people manage the stress, particularly teenagers. So I can see a lot of people, particularly girls, because there's a female preponderance around 16 to 18 when there's a lot of exam stress. The wheels seem to come off and they get a lot of dizziness. A lot of patients do really well with riboflavin, vitamin B2 that is, or magnesium supplementation. So it's 400 milligram tablets a day over the age of 12. It does turn the pea bright yellow, vitamin B2. But I've got quite a lot of patients whereby taking those vitamin supplementations, paying attention to sleep, and getting regular outdoor exercise really brings their symptoms under control nicely. Medical treatment, if the attacks are fairly infrequent, less than once a fortnight or so, and probably a triptan. So zolmitriptan nasal spray I find to be really great. That's licensed for greater than 12 years old. In younger children, you're in a bit of a bind because there's no real anti-migraine medication licensed for kids under 12. Rizatriptan, which is available as a sublingual tablet, is licensed in the States for children over 6, but it's not licensed in the UK. But American children are pretty similar to my mind to British children, so you probably go along and explain to the parents that it's licensed in America but not in the UK. It's thought to be safe, and you prescribe it off license, but you need to be aware of the consequences of that. You need to be careful about explaining that it's not licensed in the UK. Where the attacks are happening maybe more than every fortnight, you want to give thought to prophylactic medication. I would tend to start with a very low dose of nortriptyline, 10 milligrams at night. I put them on that for maybe 2 weeks, and then they can increase by 10 milligram steps up to a maximum of 50. But a lot of people will get symptom control. The alternatives beyond that are propranolol, but that causes bradycardia. So if you're a very active teenager, that can cause problems with exercise. And of course, you can't use it in asthma. Or there's topiramate, but that is very teratogenic. So you've got to be very careful about pregnancy advice, because they really can't get pregnant when they're taking topiramate. Where there seems to be a menstrual element to it, whereas a premenstrual migraine, then you may wish to ask the GP to consider a review with regard to progesterone only pill. An interesting point, if there's an aura element to the migraine, which there can be in vestibular migraine quite a lot, then the combined contraceptive pill is contraindicated because there's a significant increased risk of stroke. So I think the overall risk of stroke for a young woman under the age of 30 is 1 in 100,000. If you've got migraine with aura and you're on the oral contraceptive pill, the risk goes to about 33 in 100,000. So it's still really small, but it's 33 times higher. So don't, I very much doubt any ENT registrar is going to be prescribing the combination pill, but just bear that in mind. Okay, vestibular migraine. Happy to answer any questions about that on the comments if necessary. So this is a very rare condition that I, hand on heart, I'd never heard of until I was doing my reading for this presentation. It's called episodic ataxia type 2. It's a very rare autosomal dominant calcium mutation. Interestingly, it's the same gene, CAC-NA1, that's implicated in benign torticollis and benign recurrent vertigo of childhood and some migraine, but it's a different mutation. And these people present with episodic ataxia. Wide-based gait, typical ataxia, problems with coordination, double vision, dizziness, and often usually dysarthria. It typically begins in the teenage years, and it can be triggered by physical or emotional stress, so extreme exercise, tiredness, or high emotion. During the attacks, they're very ataxic, and even between the attacks, there can be this mild diplopia, this downbeat in nystagmus. It's really rare. I've never come across it, and the interesting thing is that you treat these people with azithromycin, and about 75% of them respond. So it's felt to be a diagnostic test if they respond to azithromycin. I've got to be honest, if I was thinking that someone was having recurrent ataxia, I would probably, if I thought it was this, I'd probably be asking them to be seen by a paediatric neurologist. But just to be aware, if there seems to be some ataxia rather than a pure vertigo and there's some dysarthria during the attacks, then potentially it could be one of these conditions. Meniere's, probably the best known cause of recurrent vertigo, probably the most overdiagnosed condition in balanced medicine. Everyone I see in my clinic has been told who's got recurrent vertigo, they've been told at some stage they've got Meniere's disease. It's not quite unheard of in paediatrics, but it's not far off. I don't think it really happens in young children. If you think it is, it's probably vestibular migraine. But there are rare reports of onset in the teenage years. Now, I can recall one child that I didn't see, but was reported to me by one of my old consultants, who was at 15, 16 and presented with Meniere's. And it was definite Meniere's because they had the episodic hearing loss, tinnitus, vertigo, and they had a low frequency sensory or hearing loss. Bearing in mind in vestibular migraine, you can get hearing loss during the attacks, but you wouldn't expect to see the low frequency hearing loss, which is the hallmark of Meniere's. But you can get it, but it would definitely not be my first port of call in making a diagnosis. I'll be thinking of vestibular migraine. BPPV, really rare in children, very rare. I mean, one of the most common causes of recurrent vertigo in adults, particularly elderly, but very rare in children. It has been reported as occurring post-head injury, which makes physiological sense. And there's been one report of it occurring post-cochlear implantation. So a kid who had a cochlear implant went on a roller coaster and developed BPPV with a classic positive Dix-Hall pie test responding to the Epley manoeuvre. So there was a wonder whether this might have been predisposed because of the cochlear implant. It was one case report though. It can also occur again with wide vestibular aqueducts, and sometimes vestibular migraine, you can get attacks which mimic BPPV. As you'll all know, it's paroxysms of short-lived vertigo triggered by movement with a positive Dix-Hall pie test, which you should all know how to do. And the treatment is the Epley manoeuvre, which again you should all know how to do, and it's the same as adults. But I would not jump to that as my first diagnosis in a child. Otitis media. So we all know that children with glue ear often have delayed gross motor skills. They're often clumsy children. And this can worsen during acute episodes. I found one study which showed that about 20% of children with glue ear had delayed motor skills compared to 0% of a control population. So I think they looked at 140 children with glue, measured their development, and they found that 20% were delayed. And they took 50 control children, and none of them they all had normal development, as you might suspect. So there's this feeling that otitis media, glue ear that is, can cause a motor delay. I think we've all seen that. actually, I couldn't find a great deal of objective evidence for that apart from that one study. Remember, there's good evidence that if children have got an underlying migraine disorder, benign vertigo of childhood, torticollis, that glue can exacerbate that. So treating with grommets, I would have a lower threshold if there's an associated vestibular disorder. We've talked a lot about the ENT causes, but it's probably worth mentioning that there are lots of other causes why kids get dizzy, and they're probably more common than the conditions I've described. Orthostatic hypotension, sorry. So child stands up quickly, feels a bit dizzy, feels a bit flushed, world seems to move, they sit down, they feel better, or maybe they faint, okay? And this is probably more likely if they're dehydrated, so if they're not drinking a lot, or if they're exercising in a hot environment, or they're skipping meals. So particularly in the teenage years, that's quite common, so you want to make sure that that's not just what you're dealing with, and it's a true vestibular problem. So I think I've run out of things to say, really. So a few summary points, a few take-homes. So young children aren't going to come to you and say, I feel I've got vertigo. They often won't be able to describe how they feel, and they might use other terms, or you might need to rely on the autonomic symptoms. Migraine disorder is really the most common in children. Those pre-migraine conditions, the benign torticollis of childhood, the benign recurrent vertigo of childhood. There's this concept of the vestibular march. So torticollis to recurrent vertigo of childhood to vestibular migraine. That can be familial as well. And there's an association with wide vestibular aqueduct. So if you're picking up these conditions in children, you're suspecting them, you need to be doing audiograms as well. Remember, paroxysmal vertigo of childhood is not BPPV. If you just do a Google search, you get a lot of very confusing results, but they're definitely separate entities. And when you're treating an older child with vestibular migraine, you really need to focus on those lifestyle changes first, which is easier said than done. A lot of people just want to have a tablet and get on with their life, but that's not the best way to go about it. They really need to pay attention to their lifestyle factors and try and engage the child and the family in that as well. So that's it. That's all I've got to say. If you've got any questions, if you put them in the comments, I'll do my best to have a conversation with you. I've shared all these slides with Andy, so if you need copies of the PowerPoint, they'll be widely available. Yeah, and thank you very much for the invitation to talk. I'm very sorry I couldn't be there in person, but hopefully I'll see you at a future teaching event. Thanks very much, everyone.